morning, everyone. Thank you for joining us for the weekly briefing on the University of Arizona Campus Reentry Task Force. I'm Holly Jensen, Vice President of Communications for the university. Today marks the 10th briefing to discuss the university's plan to reopen our campus. Before we get started, I ask that everybody in the room please mute your microphones. When we come to the question and answer portion of today's question, I ask that all media outlets please type in your name and news organization and raise your hand in the chat. We are broadcasting this event live on arizona.edu/live. With us today is Dr. Robert C. Robbins, President of the University of Arizona, and Dr. Richard Carmona, 17th Surgeon General and Director of our Reentry Task Force. Thanks for joining us, gentlemen, and I'll turn it over to you, Dr. Robbins.
Thanks, Holly, and thanks for everyone who are tuning in today for our 10th press briefing. It's very exciting. Today, we remain excited for the semester to begin as scheduled on August 24th, with a mix of in-person and remote instruction delivered in 4 modalities, as we've discussed previously in these briefings and in other communications. We're taking an on-ramp approach to all in-person and flex in-person classes. As I shared last week, we expect this on-ramp to span several weeks. Its ultimate length will be dependent on the public health conditions in our county, state, and our nation. From the beginning, our plan has been informed by the expertise of our public health faculty who have participated in every level of planning and who will continue to take part in the implementation of our reentry plan. I want to thank the public health and all other faculty members who in the last week provided valuable input on specific metrics and indicators to enable our reentry, particularly our decisions on the length of the on-ramp. Dr. Carmona will go over some of their concepts in a moment. The metrics and indicators they recommend match the approach we have been taking. And as we have been in dialogue all along with these faculty members through the ICS process and the reentry task force. If we see any indication that warrants concern or a change in our plans, we will communicate with our students, faculty, and staff as we have done through these briefings and in other venues. We are following the data at every stage of planning and implementation. This is why Dr. Carmona and the ICS team provide me with a detailed update every day in their situation report. As I have said all along, we need students, faculty, and staff to follow public health measures to minimize transmissibility of this deadly virus. If we identify any issues, whether a change in the public health conditions or non-compliance with public health measures among the campus community, we will adjust, and we will adjust quickly. As parents, you expect that, and our students, faculty, and staff deserve it. By following good public health practices, reducing the number of in-person interactions each day, wearing face coverings, physical distancing, and following good personal hygiene and disinfectant routines, you can help us return to campus safely. Whether you are in person or learning online, we support you, and we will all get through this together by working together as one team. And we will be data-driven, and we will follow the science and the data as we make decisions. So the good news, I think, is that the data is trending downward. And I want Dr. Carmona, as he does every week, to go through some of the data and continue his cautious optimism as we've talked about every week. So Rich, could you take it over and look at some of the data for us?
You bet, Mr. President. Thanks so much. And again, good morning to all of those who continue to join us on a weekly basis for the updates. We are very fortunate to have such a committed, passionate faculty at our side. I mean, that are 1,000 strong that provide this input for us. So can I get the very first slide, please? So as we've done every week, we give you an idea of where we stand as cases. And what's important that is not on this slide, you're all hearing the news every single day and looking at other states. I'm following Texas very closely, and Houston is tapped out, for instance, and they're having to export patients and really having to curtail lots of activities because their ERs are full, their ICUs are full. We look at other states that are still struggling, Florida, and we look others that are emerging. And when you look at our numbers, again, cautiously optimistic, but we continue in a trend in the right way. You'll see the peak of our cases was in early July, and you see every week since then to the end of August or into August that we continue to decrease the cases on a day-by-day basis. So this is very good, but we can't be complacent. Now we have to work even harder, bear down even more to make sure that those cases don't come back up. Next slide, please. And you see here a comparison of declining cases across the board from Florida to Texas and so on. You'll notice their peaks are much higher. When you look at Arizona, our peak was a little lower, but again, they're trending down. Florida and Texas are still struggling significantly. So again, we're happy, but we're all in this together as a nation. And because of portability of disease, if you will, people traveling, we are very cognizant of what's happening in states around us as well as the United States, because we are a global university. We have students come from all over the United States and a significant percentage that come in internationally. So we have our hand on the pulse of all of those communities where students come from. Next slide. Again, the Pima County cases by week from June 1st, you see again, our peak is end June, early July. And since that time, we have consistently lowered the amount of cases as the president has alluded to. We are all very pleased at this performance. We also recognize, though, that it is going to take a continued concerted effort to be able to flatten that curve, to decrease transmissibility maximally so that we create the safest possible environment at the University of Arizona. And that's not only dependent upon us, it's dependent upon our surrounding community, the county and the state, because there's traffic moving back and forth and people in cars and so on. And so as the president has alluded to many times, it is important we have partnerships. And we're working closely with the city and county, sharing information, sharing practices, working together for testing, so that that same 1.1, 1.2 million people in our geographic area, some live in the city, some live in the county, some work at the university, the largest employer. Some of their students go here. So we look at this as a large community of which we are almost a city unto ourselves with 60,000 people at the University of Arizona when we're at our peak. So we're doing very well with these partnerships. But again, we are not going to become complacent because the numbers look good today. Until it's extinguished all over, we're all in this fight together, and we must continue to bear down and do everything we can to prevent transmissibility of this disease. Next slide. The deaths, great numbers here. You see we peak again at that time around July, early July, mid-July, and you see we drop down. Then we peak again toward the end of July. And, you know, there's a lot of conjecture as to what that might be. Could it have been the latent period after the July 4th holiday, a number of people traveling, vacations increasing? All of those are possible. But what is most important on this slide is that the deaths have dropped precipitously. So as our cases are dropping, the deaths, the mortality is dropping. All good indicators, but now we need to even get tougher to make sure that that number does not go up again. Next slide. ICU beds pretty flat, as you can see, and we're pushing 80 to 90% depending on where we are in the state of Arizona. The good news is we have surge capacity. We're hoping we never have to rely on it. But one of the predicates of the plan that the president has announced is that one of the restraining things will be if there are no beds, if there's not enough staff in the community, if there are no ICU beds. Not that we are anticipating anybody will need them, but as a part of contingency planning, we must ensure that there's a buffer. Should an untoward event occur, we have the ability to take care of our students, staff, and faculty. But if those beds go away for any reason, then we have to reconsider our plan. And that's something that the president has emphasized. And it's something that has even become more granular now in our metrics, as the president announced that our faculty at the College of Public Health has been working diligently to give us better metrics as we move along. We've been using a more high-level approach, a macro approach in what was trending. We've mentioned it a number of times: ICU beds, hospital beds, the mortality, the morbidity, and all of those things. But now we're getting better numbers to be able to look at that, looking at percentages, looking at a risk in a different way. And we give great thanks to our College of Public Health, as well as other faculty have contributed to that knowledge base, so we can be better in predicting the risk in our community. Next slide. Ventilators is another surrogate. Most of the ventilators being used in Arizona are in fact being used by COVID patients, generally between 50 and 60%. And why this is important is, as we head to the end of the summer, we expect then that our bed usage will go up just because flu season starts. And we know from historical records that as our snowbirds come in, the population expands, more of a senior population, they get the flu, some have complications. That's when our beds fill up. So we have to be very careful about that, because we know what the expectation is for bed utilization, staff utilization, ventilator utilization on an annual basis based on flu and the so-called snowbirds coming in, and our own population who will suffer from the flu. And now we have COVID-19 on top of that. So we watch this very, very carefully, because these could be limiting factors in how aggressive we are with our reopening based on the availability of community resources. Next slide. And this is maybe the most important slide of all today. And this RT is an epidemiologic data point that tells us about transmissibility. And you'll notice what this looks like, this little roller coaster. And you look where sheltering started, you look at sheltering ended, and you see a peak there. Not surprising. People go out and they start their usual activities, you see a bump in transmissibility. But what you see at the end, the green line that's down about 0.80, 86, 87, what's interesting there is that green line below the baseline tells us our transmissibility is exceptionally low. We're right where we want to be. We want to continue to push it down. That's the trend we need to keep pushing on. And the only way we can do that is based on what the president has said: washing our hands, social distancing, wearing a mask, all of the best practices in public health that we continue to monitor. And as the science evolves, as more knowledge about this unknown, invisible threat, COVID-19, becomes available, we incorporate that science into our weekly briefings, into our policies, to maximally affect the ability of our students, staff, and faculty to be safe and decrease the transmissibility. Next slide. Bobby, I think that all of the things that you have been harping on for some time are showing good fruition here, in that the numbers are moving in the right direction. It seems we're having a lot of compliance. As we've talked about, our risk is with students coming in that they have to be compliant. And then you've spoken to parents, I've spoken to parents to tell them, your son or daughter is going to be at risk at home unless you lock them in a room. You bring them here, we're doing everything we can to make this campus as safe as possible, working with our community, because we know the students will go in the community to ensure that we have this. But I think we're off to a good start here. And again, I think with your leadership, we've been able to present a very valid case why it's a reasonable approach to accommodate students who want to be here, again, voluntarily, faculty who are here voluntarily, and we can get moving in the right direction. And with the phased-in approach we're looking at, we can keep testing every week to see how we're doing, and then keep opening even further.
I think you're muted, Dr. Roberts.
Yeah, E6, error on the shortstop. Wish that were my first one of the day. Probably won't be the last. But I think you bring up a good point, and we've said this over and over, that students are going to choose whether they want to come back or not. The faculty and staff, they don't necessarily get to choose, but we've made it, working with the provost and working with the deans and heads of the support units, to say, if you have any risk factor, we don't want you coming back on campus. Remember, we're trying to de-risk the population by having as few people as possible to deliver the education face-to-face on campus that will provide high quality to our students. But to be clear about it, if you are a staff member or a faculty member, you can work with your supervisor to work out a solution for doing your job remotely. If you can't do that and you think there's an irreconcilable conflict, then you can go to the Disabilities Resource Center where you can work out something with them. Even having anxiety, even if you're not, you live alone and you're below 60 years old and you don't have any comorbidities, but you're just afraid to come back, then you can be given a waiver, a dispensation, just because of your anxiety. I want to emphasize that. Now, I also want to acknowledge that there's some jobs that you just have to be on campus. You can't teach remotely. You can't do your job remotely. And of course, what I always default to is doing a heart transplant. I don't know how you do a heart transplant from a Zoom room. So what if there's someone who has comorbidities? Well, they either have to make the decision that they're going to take a risk, which we would encourage them not to, or we can redeploy them to do another job like telehealth or something else. The final option would be one could take a leave of absence from the university and your job will be kept for you until you come back. Maybe you want to be a consultant or do something else with your life for a year. So I want to emphasize that there's a lot of flexibility, and the students, of course, they choose by whether they want to come here and pay tuition. So last week, I pushed to get us back. We will open on August 24th, but how we ramp in is going to be really important. And either as we were going on air last week or as we just finished this briefing last week, we got a very thoughtful document from our public health colleagues. And I know you had met with them, and I really appreciate all the hard work they've been doing with your ICS team together. I meet every day from 3 to 4 o'clock with the testing team to talk about antigen, antibody, PCR testing, how we're going to deploy it. And I think we have some slides about testing. But before we get to that, Rich, I think we should have the slide that shows the discussion that we had yesterday with our public health colleagues, and put up the data that you as ICS and this group of public health experts will watch the data every day and then guide decisions about how fast we ramp into the semester.
Right. I think that's a great point. Let's put that up so we can show everybody and have a little discussion around it. So what we have here is a document this is really a summary of a much larger document, but we just wanted to give you an idea. As we've gone through these on a weekly basis, a number of reporters, and rightfully so, have said to us, well, how will you know? What is a trigger? How do you know when to stop or when to go? And, our faculty heard that, and we heard it because we were dealing more with general triggers. And so the faculty said, let's see if we get more specific. And they worked really hard on this and gave us a draft last week at the beginning of our press conference. We discussed it through the week, and now we're looking to implement that. Again, another important demonstration of the teamsmanship that is occurring here, that as all of our faculty members are watching what we're doing and they see innovation, they see a way that they can innovate something. They see a way that they can make it better. And, I can tell you, ICS is inundated with ideas from all disciplines on the campus about how to do certain things, everything from the digital to the in-person to epidemiology and public health. So what we have here are external and internal metrics, and the external metrics are essentially what's the county doing, what's the city doing, what's the state doing. So we give you some ideas there, and we actually then start looking at, for instance, 7-day rolling averages for different cases. We look at rolling averages for inpatients suspected of COVID, of ventilators. So the things you've heard us describe before, now we have more granular information to be able to better predict. And what we're really excited about, because this is brand new, as we aggregate all of this data and we are able to do a retrospective review in the past, we'll be able to show what worked and what didn't work. We'll be able to actually get what we call predictive analytics. So when we're faced with something like this in the future, we'll be even better prepared because we've learned from this brand new virus threat that nobody in the world has ever seen. When you go to the internal ones at the university level, looking at our own trends, at the university level, as you go down for capacity, how many tests are we doing? What are the results of those tests? And then, of course, tracing and treating. So what you see in those titles is really nothing new. From day one, when the ICS started this and our public health colleagues did, and all the other faculty that gave information, these are the kind of issues we knew we had to track. But now what you're seeing is we're getting better at tracking them because our public health scientists have put a lot of effort into defining those trigger points that will help us decide, do we move forward or do we stop right now because maybe it isn't safe to go forward? What do you think, Bobby?
Yeah, I think that it was an incredible meeting we had yesterday. And of course, we've been talking all along because the faculty have been our greatest asset in terms of helping develop policy around this. But we just didn't have it codified until we got that document from the group, I think last Thursday. And so we began to set up a meeting, and yesterday we had a very positive meeting with Dr. Gerald and so many of our public health colleagues and medical and nursing colleagues. So I think going forward, certainly, there's been a big theme this last week about shared governance and the faculty's participation in decision-making with the administration. Look, I welcome this. They're the experts, and there will be a committee that will look at these numbers every day. I ask them, oh, I'm so excited. Can I meet with you every day to discuss these? Because I meet with the testing team every day. I meet with the ICS team every day, and they go, well, we actually have faculty jobs. We got other things we got to do, and we probably should meet only once a week. We'll obviously all be watching this data every day, but let's have a meeting once a week where they give me their recommendations about, okay, should we move to more in-person classes? We've proven we can. The systems are in place. We can actually test, trace, and isolate. And one of the things that's on here is the capacity for isolation that we talked about. Well, should we have a percentage of isolation beds? That one, I think we're initially, Rich, we only had about 100 beds. We're now over 300 beds, and we have capacity to isolate positive individuals in overflow hotels if we need to. That one, I think we're going to be fine with, because one of the things that I always said was, well, how will you know when this, when it needs to go back to what we had in the spring? And it'll be when we can't isolate safely and have beds for isolation, when there are no hospital beds, when the ICUs are full. We want to be able to have these metrics and watch these metrics with the public health faculty experts and with the city and county. We also had a fantastic meeting this week, Rich, that you facilitated with the mayor and Chuck Huckleberry and Dr. Cullen from County Health, and particularly around sharing our resources for testing, tracing, and isolation. Right. And I think that's tremendous. Some of the things that we've gotten, we talked about in terms of the number of cases, we continue to see the number of cases come down. We've got a couple of weeks, actually, some of the RAs are coming in, I think this weekend. So we're starting to see people show up on campus. I'll remind everybody, we've had over 7,000 people on campus over the summer, and we have not seen any major outbreak. So it's going to be different when our students come back from all over the country. Right. So we're prepared for that. And just that first metric that we discussed yesterday, the first day our students come back to be in the dorms, there are about 5,000 of them now. we know that probably 200, 250 are going to test positive, and we're going to isolate them. They're all asymptomatic, and we're going to take them out of the population and have them isolated. So we're going to see cases go up periodically, but we will work with the public health experts as we slowly ramp into the semester.
Well, Bobby, a couple of things are worth expanding on there. One, that, the many teams that have come together with subject matter experts in so many different disciplines in order for us to come up with this Wildcat plan. Number one, the incident command system, which basically is the funnel that captures all of that, distills it, and then be able to give you advice on how we should move forward so you can make the best decision. But I think what the public needs to realize too, we are in very uncharted territory here. Nobody has ever dealt with this virus before in the world. So we extrapolated data from the coronavirus experiences in the past, SARS, MERS, et cetera. And we assumed that it'll act a little like it. Well, it does act a little like it, but it's also a lot different in transmissibility, lethality, and so on. And some of the rare diseases that are coming up as part of the vasculitis that we talked about, the heart problems that you're seeing. So the public needs to understand, and I think in our staff and faculty who are not involved, it's not that we're changing our mind. We're having meetings every single day about evolving science and how to better adapt the new science into everything we're doing. And so, for instance, as you remember, when we started, we were talking about 2-week windows. And then people said, no, it should be 5 weeks. Then it was 3 weeks. The problem was we were learning more about that virus and how it acts. And 5 weeks is very safe. 2 weeks is a little too short. So we said, well, how about 3 weeks? And so we are pushing the limits of science every single day as we promulgate policy. And that's the way it has to be, because there's no textbook for this. We can't go look it up. We can't Google it. We are actually providing the Google information now as we look at our colleagues around the country. So I'm very, I'm actually very happy that we've got this great team around us who continue to provide the information. And the other thing is, everybody doesn't agree with everything. We have some pretty spirited discussions as to how to move left or right or forward or back, okay? But the good news is, at the end of the day, we come to a conclusion that benefits the campus and the community on each and every one of these complex issues.
So one of the metrics that wasn't included that I pushed for was the wastewater-based epidemiology. Yeah. And many of the, and Ian Pepper, Dr. Pepper, is just a tremendous international expert in this regard. And I think Ian is doing really land-breaking work. Just looking simply at sewage, and if you just look at the county level, he can tell you when the number of cases go up, just at that macro level.
Well, so what's interesting about that, Bobby, is that, we all were embracing that. We read the literature, and you say, okay. And I remember we went, again, we go through the ICS, and we'll go to Chris, who runs our campuses, okay? Basically, he's in charge of all our facilities. And the question was, okay, we'll start sampling, but how many pipes go into this wastewater disposal? How many buildings does it cover? Can we put filters? So from something that sounded extraordinarily simple, it became extraordinarily complex, because if you get a hit on 2,000 students in 3 buildings, how do you deal with that? Okay, do you do pool sampling? Do you do individual sampling? But I guess what's important is that the public and the faculty and staff not involved realize the extraordinary due diligence that goes into this detective work to track it down to the lowest common denominator to figure out how do we use it to keep people safe. And those are the conversations happening every day that are reflected in your sit rep every 24 hours.
Yeah, so I believe that we will continue to have discussion. The faculty didn't really want the wastewater-based epidemiology to be a metric on the list, but I hope we'll, because it's so new. But it's being used certainly across Europe, and I think there'll be utility, and it'll be at least one more data point we can look at, because Ian, I think, is going to be able to predict hot spots before anybody ever becomes symptomatic, and that's what we want to know. So there'll be continued dialogue with this committee of faculty members from across the campus, and that'll keep us informed as we move forward. The one other thing I wanted to mention about testing is that we're going to test every individual moving in the dorm. They have to have a negative test before they move into the dorm. I want to strongly encourage every person returning to campus to come and get a test. It'll be a fast test. It'll be an antigen test. You'll have an answer on your phone within an hour. Before you come back and engage with your friends, because you may be positive and not know it.
Right.
And so if you come back, please come. I want to be able to offer everyone, every student, every faculty member, every staff who is going to come for essential activities, essential courses that, organic chemistry lab. The provost and I did organic chemistry lab last Friday. We got suited up. We went through. We were physically distanced. I was very impressed with how the chemistry department is taken this very seriously about the essential courses that are needed for people to continue to progress through their earning their degrees. But I hope that we will be able to offer a program. We're going to have sentinel testings where we will do random testing of people to look for new cases. But I'm hoping to be able to announce maybe in the next week or two at one of these briefings that we will be able to offer every 2-week testing for anybody that's coming on campus. That would be 8 times over the course of the first term. And then I think that will help us to find those asymptomatic cases. And I'm hoping it provides some guidance to the team about watching the number of cases and whether we need to de-escalate or down ramp our activities.
Yep, absolutely. I think it's worth here also reinforcing what you say repeatedly. Since we know that it could be 25 to 30% of people asymptomatic carriers. That is, you feel fine, but you're shedding disease. You become a super spreader as you're moving around. Wear your mask, wash your hands a lot, stay socially distanced. All of those simple things will help us to keep the university open and let the other students, faculty, and staff come in as we phase them in over time.
Yeah, so Holly, I'm sure we got lots of questions from the press, but I just remind everybody, bear down and mask up.
Well, one quick thing, I think you guys have talked a lot about testing, and I think maybe this is the good time to talk about all of the different types of testing we're doing here on campus.
Yep.
And so I'll have them bring up the slides and then you can just quickly run through and then we'll get to the questions.
Okay, Rich, go ahead.
Okay, please put them up. So the antibody test. Now, this is a test, they draw some blood and they look to see if you have antibodies. Antibodies are basically the way your body fights off an infection. The antibody responds to the foreign substance that comes in and hopefully it eliminates it or stops it. The antibody testing lets us know you've been exposed. It does not tell us that you have the disease today. So its ability to help us acutely is not so good because it gives us a bigger picture epidemiologically of how many people have been exposed and who and immunity issues. And immunity is becoming important now because we're learning that immunity may be a little different with this virus, that it may be short-lived, which means that maybe if we have a vaccine, you'll have to have a booster. So all of those things it helps us with. Next slide.
Yeah, Rich, before you
Go ahead. Yeah, Bobby.
Yeah, I just want to say it was really important. I'm so proud of the team that developed the antibody test here. There's going to be a major publication that is going to get a lot of attention about the work that was done here with our scientists, our virologists, our immunologists around this antibody testing. It also allows us, because they developed it so quickly and it was so accurate and so early, we can now bring those people that were positive back 4 to 6 months later and find out and help to answer the question, does immunity persist? Moreover, it gives us the opportunity, because we have all of this data, that the vaccine companies really want to partner with us because we have this data. So I think we're in active discussions with a lot of the major manufacturers of potential vaccines. And we would not be in this position at the University of Arizona had our incredible faculty not done all this work.
Yeah, they've done a fantastic job. Next slide, please. So the PCR test. So that's the PCR means polymerase chain reaction, and that's done with a nasal swab. And it's a molecular diagnostic technique that detects the genetic material. So the virus is what they call an RNA virus. If it's in you, it detects those particles and knows that you have a virus in you. Now, you have to be careful because you have to look at what's called sensitivity and specificity. It has to be specific enough that it's not going to pick up any coronavirus, but you want to know specifically about coronavirus 19. So the interpretation is not as easy as it might sound. It's not like yes or no. You have to know when the test was given because it takes time for you for that virus to grow in your body. If you got exposed yesterday and you take a test today, it may be negative just because your body hasn't mounted a response yet and the virus is not detectable. So there's a lot of nuances that we've learned about in this testing. But this is an important test, sometimes used as a test to confirm the diagnosis, and one that we have been using for some time. It's one that also takes a little bit longer, which doesn't help our epidemiologists because we can't wait days or weeks. We need to have the information right away, which is the other test we'll talk about in a minute. But Bobby, you want to say anything about the PCR test?
Well, only that it is sort of the gold standard. It does take longer. You know, if as our epidemiologists who are doing the incredible contact tracing work in partnership with the county and the work that's being done with the SAFER program here, you've got to have the results back within 24, 48, at most 72 hours, because the contact tracing has a diminishing return after that point. So early on, we knew we were going to be at the end of the supply chain. And so we asked that our scientists start building our own kits. So we have done that. And we've taken the PCR testing that we're doing on our students, faculty, and staff in-house. And I'm very proud of all of the work that's been done here to do that. We've also made test kits and given them to our partners when they were having trouble getting them from the federal government, to our native nations. We've been active in supplying them with kits, but that we can do our own testing and get it back within 24 to 48 hours is really, really key. Right. Testing, but then get the results back quickly so we can contact trace and then isolate.
Right. Let's go on to the last test then. So antigen testing. So this is one that will provide a diagnosis for active infection. And the good news is this is the one we're using to test all of our students that are coming in, faculty and staff as well, because when the students come in, they get their test, it's scheduled. They have to take a little walk for a little while or sit it out, and within an hour they get a response on their phone, and that gives them the, if you will, the gate pass to get into the dormitory. You tested okay, you're ready to start. So it's designed for rapid detection. It's specific for the virus, but not as sensitive as a PCR test, but it's really a great screening tool for us. And the timeliness is really the most important part as it relates to antigen testing. And it's something we do very well here at the U of A. Bobby, any comments?
Yeah, no, I'm a big fan of this test. You point out that the specificity and sensitivity is not quite as high as PCR, but it's really good and it's fast. And as more tests have been done, the sensitivity and specificity is increased. Not almost as good as PCR, but not quite as good. But for our purposes, this is great. The real issue is that there's really one company. There are other companies that are developing, but there's one company out of San Diego that we, because of our antibody testing again, because they want our antibody data, we've got a very good relationship with them and can get kits from them. I think we had about 40,000 kits to be able to do these tests. And we think we'll continue to be able to get these reagents so that we can offer what I was alluding to earlier, which is testing every 2 weeks for people who come on campus who have to do their job or have essential courses that they have to attend. We want to be able to offer them, sort of every 2 weeks a test, and it would be an antigen test so that you can get the results back quickly. Okay, Holly.
Perfect. So following on that, our first question actually got text to me, and it's from Claudia at ABC 15. And she wants to know, what is the process for us when a staff member or student tests positive for COVID?
Rich, you want to take that?
Sure, happy to. Very proud. This is something that all the staff and faculty have worked on very consistently. A student who tests positive, or let's say becomes symptomatic, then gets tested and they're positive, student health is set up for them. And basically they'll move from their own dorm into the quarantine dorm. If they're positive, they'll stay there for the prescribed time. They can take their classes digitally. They just bring their laptop with them. When they're better, they go back to their dorm. That's it. Faculty members, same thing, that we contact. Well, actually, one of the more important things I think I should put in there that we forget about is on the logistical side. We have set up these special response teams that when anybody tests positive, right away, the facilities management has teams that get to that site, pretty much evacuate everybody. They sanitize that whole area, and Bobby and I and the team get a alert that we have a hit in this location. We're sanitizing right now, and then when it's cleared, we get another hit that says this site is okay to occupy once again. So it's a very important part of our process, but often you don't see it. It's invisible. They swoop in, they clean it, they move out. And faculty is the same way. They can access through student health, or if they are live nearby at home, they go home and they quarantine at home. They have their personal physicians as well through insurance. So there's a dual path there. But student health is willing to work with all of our staff and faculty should they become positive while on campus. Did I miss anything, Bobby?
Nope, that's great.
Okay.
Great. And I think you answered almost all of her follow-up questions in that one single answer. So I will turn it over. Our first question comes from Rachel from the Arizona Republic. Go ahead, Rachel.
Hi, am I unmuted?
You are.
Okay, great. I'm wondering about the Ashford deal. President Robbins, the faculty have said they're very concerned about this deal and that they weren't properly consulted. They seem to be concerned tarnish the U of A's reputation. So I'm wondering, how were faculty consulted, and do you believe it was adequate? And then do you agree that there is, potential reputational damage because of this deal?
Well, I would say this gets back to several issues we have around reentry, around the furlough program, about the Ashford deal, around shared governance. And I think that the faculty, a certain group of the faculty don't believe that they were adequately consulted. I think that we can always do better with communication with the faculty, and certainly are committed to following shared governance and working with our colleagues. This was brought up at the Faculty Senate this week around public health experts. You're just making willy-nilly decisions and not consulting our faculty. So therefore you're violating shared governance policies and good practices. We listen to our experts. We've been working with them all the time, and we're happy to have them be part of the process of helping advise around decision making. The same thing with the financial crisis that we're in at the university. So your specific question is around Ashford. So this is a deal that that was complex and very sensitive, and of course. There have been other deals like this, most notably the Purdue Kaplan deal at Purdue University, and former Governor Mitch Daniels, who's now the president of Purdue University, faced these same criticisms from the faculty. I'll tell you, the process was not as robust as the usual shared governance process, because we were contemplating doing a deal with a publicly traded company. And people questioned why faculty members had to sign a non-disclosure agreement, which over 200 were signed by leadership in shared governance and in faculty and deans and other leaders across the university. And we did have one leak of this. Thankfully, in my opinion, it didn't stop the deal from going forward. But you get into all kind of SEC violations, and so that's why we ask people to sign this non-disclosure agreements. After having done that, I would say that there was certainly a vocal group from the faculty that raised concerns about this deal. I can tell you there are a lot that did support it. I don't know, we never took a vote, but there were people on both sides. So I was left with trying to make the best decision that I thought, as I've tried to do with Reentry, with the financial situation, and with this deal. Not everybody's going to agree with every decision I make, but I try to listen to people, take under advisement what their concerns are, and I made the decision because I think it's in the best, value and future of the university to move forward with this deal. It helps us to serve a population of students that are often left behind. And those are individuals who may not have had the opportunity for whatever reason to go to a university out of their high school education. These are primarily working adults. And I am very excited and proud that the University of Arizona is going to serve this population of students. The reputational hit, I'm always concerned about preserving the reputation of the brand of the University of Arizona, without question. And one of the issues, of course, is that Ashford was a for-profit university. And there have been practices around aggressive recruiting and individuals not finishing their degrees, but having large debt. This is going to be now under our management, our guidance, and certainly we will not participate in those kind of practices. And WASC, who's the accrediting agency for Ashford, has given a report saying that all of those previous practices had been addressed. And as we did our academic due diligence and our governance due diligence and business due diligence, we were satisfied that we could go in, take over this university, serve the students, and provide our mission support of being a land grant university. It also allows us to provide online offerings and expand our online offerings, not only domestically, but globally. And I think that's where the big movement is going to be. It's been estimated that there are at least 1 billion students over the next decade in Africa that we can provide access at costs that are that they can afford locally. And to be able to have this offering in this platform, I think it's a tremendous support to the mission of the University of Arizona. There are always risks to reputation, and I'm well aware of those. I think we've got to execute and make sure that we deliver a high quality, ethical education to these students. And I'm confident that we will do that, or I wouldn't have agreed to do this deal.
Thanks, Dr. Robbins. The next question comes from Craig Smith at K-Gun. Go ahead, Craig.
Doctor, really kind of an extension of the Ashford discussion. When the university is financially stressed, is this a wise move? You're talking about furloughs, non-renews of contracts, and also a secondary question, what's your feeling about the discussion of unionizing members of the faculty?
So Craig, the first question, was that about Ashford?
It was. Okay, I would need to be sure I'm unmuted. Yes, it was. Is that a wise move financially at this point, at a time where you've discussed the university being stressed enough that you're talking about furlough plans, some contracts are being non-renewed, and so on?
Yeah, Craig, I appreciate the question. I think the last part of your question is about unionization. So for the Ashford deal, the university spent $1 to acquire it. And the deal is, I think it's already been announced in the press release. There's a guarantee of $225 million that will flow to the university over the next 15 years. So some of that money, there will be an academic affiliation agreement with faculty oversight committees to advise and watch what goes on at the university. But for services of oversight and the use of the Arizona brand by this new independent, not-for-profit university that will be named the University of Arizona Global Campus, then money will be flowed to the university that we can use to help with this financial crisis. We didn't do the deal for that. We did the deal to serve these students. And in order to be able to get money back to the university, then we've got to be successful in serving those students with a high quality education in an ethical fashion. In terms of the faculty unionizing, I support the faculty to have self-determination, and anything that, if they think that unionization is the way they want to go, I fully support whatever the faculty choose to do.
Great, Dr. Robbins. The final question comes from Charles Fishman from The Atlantic. Go ahead, Charles. You may have to unmute your mic.
There we go. Now you can hear me. Good morning. I don't think I've ever heard a university president support faculty unionization. So let's just pause and appreciate that.
Yeah, Charles. Well, look, if that's what the faculty think is the best for them for self-determination, I support the faculty. I mean, Charles, I've been accused of hating the faculty. I love the faculty. I mean, the faculty are why our students come here, for the programs and the knowledge that they impart to our students. Yeah, I'm all for that. Whatever the faculty think is best for them, I'm for it.
Okay, that wasn't my question, but I thought it was worth noting for the record. I've covered a lot of unionization drives. I have two questions, of course. I actually have 22, but I'll go with two. President Robbins, you were a little less crisp and specific today about the phasing of the in-person courses, and I just wanted to ask about that specifically. When Provost Folks first sent out the division of courses and the pacing, her email, as I understand it, said to faculty, we'll move from phase 1 to phase 2 when we're comfortable that phase 1 is going well. A week ago in this briefing, you said phase 1 is a week, phase 2 is a week, phase 3 is a week. As always, we'll watch the data. Today, you didn't sound like you were so committed to the week to week pacing. So that's question one. Question two, you put up a slide of reentry metrics and you talked about it and the county metrics and the university metrics. But if you read the slide, there's no metrics. there's a series of categories, but you didn't actually tell us what the metrics are. So what's going to happen are there going to be what's going to happen with that slide? Like that's a slide that says, yeah, we're going to think about a lot of things, but there's no numbers on it.
Yeah, Charles, I think, let me see if the questions, there are two questions. The first, I'm trying to remember, I think we need to get the slide back up there because I would disagree. There are metrics. We had 7-day declining 7-day average, rolling average. So you bring up a good point that we debated is percent of hospital beds occupied. So what you're asking for is a number. You want a number in there. And I think we could give you a range. And what we discussed yesterday with our colleagues is, do we say it's 80%? Because we put the numbers up. Rich went through the numbers today, and I think the number of ICU beds that are available are about in the mid 80s to high 80s, or that are occupied currently. So we need to decide exactly what you're saying, what these metrics will be. And it'll depend not so much on COVID activity alone. We have the data. I mean, Rich gives me the data in the situation report every day about how many COVID-related ICU beds are occupied. So as you well know, Charles, as we ramp back up, hospitals, the way they operate is they operate like hotels. They want 95+% occupancy in their ICUs. So if you're doing more elective surgery, like heart surgery, for instance, then would that be a reason not to progress in a phase? One metric out of that? Or do we say that it's 70%? Or do we look at it as a whole, in a holistic view? So I do think we will put in metrics around this, but I think this is a good start, and the experts will look at it and advise me. So that's one. The second,
Bobby, can I comment? I just want to
go ahead, Rich, and then
just to fill in the blank there. Hello, Charles, and thank you for your questions. There's never one, but we always enjoy the conversation with you. We have more granular metrics there. The idea today was present the conceptual idea, and that we're moving toward more granularity. If you look at the actual document here, which really is going to, quite frankly, kind of geeky stuff that the public really isn't interested in, but it's the numbers that we're using internally. 80% capacity, a percentage of testing, 2%, 5%, depending on what so all of those are already there. The idea today was to be able to present to the public that conceptually that we've moved from a more macro approach to a more micro approach, but we're going to even get more granular as we go on, because our team that has been working with us from the College of Public Health, and now they're going to be a standing committee that's going to be providing us regular information. We're going to get more and more granular as we learn more about this virus and how we can use that data. So this is a progression today to tell the public we are moving more toward data-driven endpoints or triggers.
Yeah, and Charles, I'll go back to your first question about my enthusiasm for 1 week, 2 week, 3 week. Because we got this data and report, I can't remember, Rich, if it was right before last week's.
Right before.
And we've had discussions for the past week, and that kind of culminated yesterday in a long meeting where we talked exactly about what you just said, Charles, in your question about, well, what are the specific metrics? And those will be in there. So for instance, that we've got to have 75% test back within 48 hours so that contact tracing will work. And they convinced me we needed to go a little bit slower because we need to make sure. I argued that we've had 7,000 people on our campus, no big outbreaks. We're testing a lot of people on campus, but they're right in that it's going to be a different mix. Most of the people who've been on campus are working in research labs and follow protocols. Betsy Cantwell and the researchers now have over 500 of our 800 labs open, and we hope to continue to open them. But I think it's a good move to be able to slow. So to be clear about it, the university, we welcome everybody back on August 24th. The first phase of this will be students that have to have essential courses. So in order to get credit for organic chemistry, that the provost and I went to organic chemistry lab on Friday, in order to get credit for that course, you've got to go. Starting August 24th, organic chemistry lab, gross anatomy lab. The fact is, our medical students have been back for over a month now, and they're going to class, and we're going to do it much differently than we did before. But there'll be about 5,000 students starting August 24th that will go to these essential courses that they need to be hands-on. And that will include, hopefully, some of our artists, our performers, athletes. That's a whole different story about our athletes. Our football players have been here. There have been over 80 of them. We're welcoming back other athletes. They have been testing, and since they've been on campus, there have been no new positive cases. Now, we had a few positives as they came back to campus, but they've been following the rules. And, you know, I was listening to somewhere, I'm a big fan of University of Miami and big fan of University of Kentucky because they're going back. And Charles, as you well know, their presidents are eminently qualified as international public health experts. New York Times reporter was embedded into the University of Kentucky planning process and wrote a really nice article. Not going to be as nice as the expose you're going to write, Charles, but this is complex stuff and it changes daily. So that's why I'm so proud of our public health school. Rich is a member. I think, Rich, you are a founding member, faculty member in the public health school, which tells you how long you've been at the university. But we depend on them to give us guidance and guide us. So you're right. We're going to roll into this, and it's almost like we've got to assure that all of our procedures, policies, algorithms, systems are in place before we move to the next phase, and prove, frankly, that we can all follow the rules when we come back together. Right. And where I was going with this, I think it was University of North Carolina or something, was the athletes were saying, you know, please mask up. It's sort of bear down and mask up. I saw ASU as forks up, mask up. And the athletes were going out begging their peer students, if you really want to come to the Dean Dome and watch us play basketball at North Carolina, you got to follow the rules, because if we don't all follow the rules, we're not going to be playing basketball. We're not even going to be able to come back to campus. So I think that we all are in this together. We're in it together in terms of health-wise. You know, we can never de-risk this totally. And that's why I say, if you are concerned and you do not want to come to the campus, I support that. I support you not coming to campus, because we're trying to have a group that of numbers that I think, Rich, at the peak is going to be a third at most of what we would normally have every day. And if other people don't want to come, then, you know, we can more easily manage a public health crisis with the fewer number of people that come on campus.
Bobby, can I just add on the thing? As always, Charles does his homework, and he gets very granular, and that's a good thing because it keeps our feet to the fire. Charles, on the issue of the changing timeline, to me, this demonstrates how our process works, because initially we went at this empirically, and Bobby wanted to get things done, and let's get it done in a week or two. Let's get them here quickly. It was our College of Public Health who said, hold it a second. Let me give you some more information. They said, let's look at incubation period. Let's look at lag time for cases. Let's look at a number of issues, and maybe we want to extend this a little. And then we were out to 5 weeks. But then yesterday we had that conversation and said, well, that's a bit excessive. Maybe 2 to 3 weeks would be something that's more in line with what we're doing. And again, emphasizing the fact that we're learning as we're moving along. Nobody has the playbook for this. And again, both Bobby and I give great credit to our College of Public Health, who continues to track this with us, embedded in all of our teams on this campus. And they said, no, you know, we think there's a better way to do it. We listened, and we're implementing those things right now. Now, again, we get hundreds of inputs every day. We can't take everybody's verbatim, but we look at everything. We decide what are the best points, and we go ahead and implement it. So I would anticipate next week, you'll hear some different things again, because we are going to depend on our scientists continuing to give us the best evolving information so that our plan is always as contemporary as possible, based on the best science.
But I
Okay,
will
let me just,
go ahead, Charles.
can I just make sure we're clear? You haven't actually put numbers to this. You said they convinced you to go a little slower. So that first week, phase 1, essential courses for people, how long do you think is phase 1 absolutely going to last 2 weeks now? And then you'll look at the data and maybe 3 weeks, or you don't know? How are you going to do that phasing now?
Yeah, I think one of our colleagues said yesterday, don't let the date determine the gate.
Exactly.
Okay.
Exactly.
So we're going to look at the metrics. And, you know, I argued, Charles, that we're already into phase 3 by looking at the number of cases, because the CDC says 2 weeks. And then all of a sudden I heard 5 weeks at Faculty Senate, and I go, hold on. 2 weeks is what CDC is recommending. We've already hit that. I don't know. We're coming up to almost a month of decreasing cases. So the cases are coming down. And then as we talked to Dr. Cullen at the county and talked to our colleagues, well, you've got to build in a couple of weeks of symptoms. And so it's probably 3 to 4 weeks you've got to see the numbers going down. So we then went on to number 2 and said, you know, a percentage of hospital beds. And we got into this nuanced discussion about, you know, most hospital ICUs run at 90% occupancy. So is that alone going to keep us from going to phase 2? So it's going to be a matrix approach, Charles, and we don't have to hit every one of those things, because some of those things can be going in the right direction, others going in the wrong. Are they weighted? You know, is one metric more important than the other? So that's why it's going to be a discussion of that advisory committee. To me, I like it on a day-to-day thing, because Rich and I and his team go at it day to day. I know the group will be looking at the data every day, but we will every week. You know, I'm hoping it's going to be 0600 on Monday morning, because I'm going to be eager to hear what are you thinking this week? Because I will want to first and foremost be as safe as we possibly can, always. And so, you know, the second phase is having 30 students per class. But remember, less than half of the classes that we're going to teach are going to be face-to-face. So I think we would, we're close to hitting all of those numbers. What I agreed to yesterday was let's slow the roll into this, because we need to right out of the gate, that first metric, Charles, we're not going to hit it, because we're going to have between 200 and 250 people who are going to test positive, who are asymptomatic. And so out of the gate, okay, we can't go to phase 2 because that one metric. So that gives us a couple of weeks to clear them out of isolation, give our testing, you know, can we really at scale deliver tests that we can report back on in less than 48 hours? Can we at scale be able to contact trace all of the cases that are going to test positive? Can we manage the isolation dorms and provide the food, the mental health, the Wi-Fi, that our students can be supported, which will be a very lonely existence, an isolated existence. And oh, by the way, they thought they were going to this beautiful dorm at the honors dorm, and then they tested positive, and they've got to spend the next 10 days in an isolation dorm. That's going to be tough. So it gives us a few weeks to roll into this, and I'm very supportive of that. And we'll watch the numbers, and if we follow the rules and the curve continues to flatten and we can maintain that, then we will progress.
All right. I know Charles has a follow-up, but we have hit an hour and 11 minutes. So Charles, you're going to have to just write us back. I'm sure that you'll be speaking with Bobby and with Rich over the coming weeks. So I want to thank everybody for joining us today. This broadcast will be linked up shortly and available for your use. We look forward to seeing you again next week.
Thanks, everyone. Bear
Thank you.
down and mask up.